Okay, I even got the little live now message. Okay. All right, so, there's already somebody here whose name I don't recognize. Hello. All right, I'll admit them. Oh wait, are you still a co-host?
No, can you make me a co-host?
Yeah, that's really important. Let's see. Make co-host. Yes. Okay, so for everybody out there in Facebook land, this is AB1400 CalCare office hours. We'll be starting in a few minutes.
4th of July edition.
Special 4th of July edition.
Special 4th of July edition.
I'm gonna admit this. Well, should we?
We can wait a few more minutes.
Okay, so we can chill. In fact, I'm gonna use the time to try to get myself back on the going in the direction I'm trying to go.
Yeah, go for it.
And so now. And if I end up falling off, I think that will make you the default co-host.
Yeah, but it didn't.
It does. And I'll be trying to get back on. I just want you to know, like, I'll be dealing with whatever I'm dealing with. But I wouldn't be surprised if that happens between now and at some point. Okay. Okay.
Well, what the heck? Why didn't you share?
Can you hear me okay right now?
Mm-hmm.
Okay. To get myself back on the one thing.
All right. Let me see.
1 minute. Would you do the letting in of people?
Yep, I got it.
Now I'm gonna be
sorry, I'm just pulling up the thingy I do, which the CalCare principle.
Mm-hmm. Yeah. Perfect.
Like that thingy, thingy. 4th of July, where we are dedicating our independence from for-profit healthcare. It'd be a great day for Governor Newsom to announce that he's supporting AB 1400. I can write his press release. It would be something very patriotic.
Totally.
All right, it's 5. I'll let in our guest.
Yeah.
All righty.
So it's 5. So we're welcome everybody to AB 1400 office hours. We are here again. We're going to start for real in 5 minutes. But welcome, and welcome to everybody on Facebook Live. Office hours. We are.
Yes. Happy 4th of July to everyone who is, out there somewhat celebrating. People are joining us, and I am thrilled to see that. I was not sure anyone would join us, and I see people joining us in on Facebook. Happy 4th of July, James. In the Zoom room, I see Danette and Samara and Dr. Bill. Happy 4th of July, everyone. We were not sure if anybody'd be here to join us today. And obviously, like I just posted, we are so dedicated to this that not even a national holiday will stop us from talking about it. And as I was saying earlier, this would be a great day for Governor Newsom to go ahead and announce that endorsement of AB 1400. You know, because we're celebrating our independence from for-profit healthcare. What else could I put in that press release for him? We could do a lot. You know, this would be a good day to, you know, go ahead and say, I support this bill and I want it to be passed. So Governor Newsom, that would be great. We'd appreciate it. Make my life a little easier right now. Just throwing that out there.
Give people that freedom that single payer healthcare would give us all, right?
Exactly. Help us celebrate our freedom from being chained to the oppressive for-profit healthcare system. You know, where people right now are probably somewhere in this state, in this fine country too, having a firework injury and probably worried about how much it's going to cost to go to the ER. And Dr. Bill, actually, you know, you're, you know, a retired ER physician. One of the statistics I pulled up, and we'll go into this again when we really start off, but one of the statistics I pulled up were about firework injuries. And last year alone, there were over 15,000 people hospitalized due to firework injury across country, not just California. But when you go and think about that 15,000, it was actually 15,600 or something. And when you think about that, how many of those people do you think just had great insurance and weren't worried about co-pays and deductibles when they walked into the ER, maybe missing a digit because they didn't properly do their fireworks set off right? But and you know, and that's why this office hours, we're, you know, kind of thinking of the theme of 4th of July. But you know, healthcare is so interwoven that even on 4th of July, we, you know, it's a perfect topic: injuries, unexpected injuries at that, you know. And so, I mean, we could talk about how that alone, you know, AB 1400 would have taken that stress away from that 15,600 people who were admitted to a hospital or emergency room last year due to a firework injury. At least they wouldn't, I mean, maybe they have to worry about if their finger is going to be reattached, but at least they wouldn't have to worry about the bill for it. And so, you know, that is something that we will discuss a little bit more. But I thought, because, you know, Dr. Bill, I know you've seen your fair share of firework related injuries and burns, you know, from kids all the way to adults who had hold my beer moments and wanted to show off. Feel free to share a story. What was your, can you remember your most wild firework related injury or story?
Well, you know, everybody always wants to hear the wildest story, but what I have to tell you is my kind of wildest experience, which was if you know anything about training for physicians, just coming out of med school, and then you go through your internship, your residency, and so all of that usually happens, you know, at July 1st, right? So that's when you don't want to end up in the hospital, is on July 1st, because that's when the new doctors all are there, you know, like that's when you get an intern who's never, you know, taken care of a patient before. That's when a new doctor starts working in the emergency room. So that happened to me, of course. When I got out of my training, I was a brand new doctor in the emergency room. I think it was in, pretty darn sure it was in Delano, California, because I did my training up in Bakersfield. And my first 4th of July shift ever was in Delano, California. And I saw a number of firework injuries, you know, on that day, my first day, and being kind of, you know, the Lone Ranger, the solo guy in this little Delano Community Hospital back then. What year would that have been? Like 1980. But you know, there's some pretty bad stuff, and it's not always like a blown off finger, thank goodness, but it can be some pretty bad burns, for example, and folks have to, even be sent to burn centers, or, burns, as you know, Gina, require a whole lot of visits, not just an emergency room visit. So, you have to come in for subsequent visits where a dressing is removed and a new dressing applied. And you might have to go for some, physical therapy, like a whirlpool kind of therapy, that's applied so that old skin comes off and new skin can grow in. And, that's what burn centers do with some degree of, of specialty. That's why these specialties exist. Well, who doesn't go in? What kind of care is avoided because of those financial considerations, where people won't go to get that care that they really need, and then they end up, disfigured, or in the case of like a hand injury, like you said, the most important thing about a hand, unless you're a high-priced hand model, like you model, I don't know what, jewelry or something, or most people need their hands to be functional. So that's what, when you have a hand injury, especially a burn, you need function. And so a burn injury from fireworks requires, a high degree of specialty care to make sure that you have a good outcome, so somebody can then use their hands for the rest of their lives afterwards. And that's why fireworks can be so devastating. But there should be no financial disincentive to getting the care you need to make your hands fully functional after an injury like a burn injury. So, so I think you're very right to focus in on something like burn injuries on a day like today. And the financial disincentive, this is another reason why America just fails miserably on our outcomes, because of what it costs people personally, to seek medical care, and they will actually refuse to seek that medical care. And again, I don't know if I saw a recent, maybe, stop me if I'm going on too long, but I did see a recent study that showed, especially in communities of color, people who have signed on to these plans offered through Obamacare, through the Affordable Care Act, on the exchanges, that have significant copays and deductibles, they will end up not seeking medical care that they need, even for something like a heart attack, and have much higher levels of death due to heart attacks, because they were apprehensive about going in to get care because of the copays and deductibles of the plan that they signed up for. So, again, this is why we need to get rid of copays, deductibles, have really universal care, whether it's in California or across the country.
Yeah, so that is actually a very good, we kind of, intro to, CalCare office hours. So thank you, Dr. Bill, for sharing that, because like I said, we're going to talk about this a little bit more because it is 4th of July. And today we are declaring our independence from for-profit healthcare, as I've said before. So welcome officially, everyone watching in and everyone in the Zoom, to CalCare office hours number 14. We'll go with 14. And I'm Gina Harris. I'm your neighborhood friendly nurse. And I'm accompanied by Dr. Ron Burbaum, who is joining us in motion. So I will be doing the introduction here. So this is CalCare office hours. This is a joint partnership that we are doing with PNHP and Healthcare for All Los Angeles. Basically, we are healthcare advocates, providers, people who just give a damn about each other, coming together to pass a single payer healthcare bill in California. This is very single-minded for single payer. Shout out to Betty Dumas Toto for that nice little slogan. It always works. And what we're focused on is passing a legislation called AB 1400 or CalCare, California Guaranteed Healthcare for All Act here in our great state of California, the 5th largest economy in the world. Even through COVID, #1 in economic recovery after COVID. As you see, our governor, we were giving out $1 million just to people to get the vaccine. So we are economically strong here in California. And the reason why I'm harping heavy on that economically strong is because one of our biggest foes when it comes to fighting the healthcare battle is, can we afford it? And I'm like, well, if we can afford to give people like $15 million to get a vaccine, I'm pretty sure we could. But anyway, I digress. So what is AB 1400? For those of you who might be just joining us on your first go round, very much so welcome. And this is definitely for anyone from a new person who doesn't even know what single payer means to our strongest advocates who always are here and, you know, contributing to the conversation. We get into some really good conversations here. So I wanted to, well, Ron, do you want to add to that really quick? I know you're driving, so I just wanted to, anything you wanted to add before I go into the basics?
Actually, just you're on the roll. No, just go for it. Yeah, I'll chime in later a little bit.
Okay. All right. So I'm going to share our 7 basic principles here, you know, for CalCare, because it quickly explains what this is in a very, very easy way, except the only problem is that I don't know what screen it's on. All right, there we go. All right, so this is our CalCare Guaranteed Healthcare for All one-pager brought to you by the California Nurses Association, who is a very strong advocate and influencer / kind of writer of AB 1400. And they are, you know, our very strong support here. And you know that nurses are kind of like the #1 trusted, like, you know, profession. I'm just throwing that out there, you know, because shout out to all the nurses, including myself. Anyway, so California Guaranteed Healthcare for All is a solution to our broken healthcare system. As you hear and as you hear us talking, our system's pretty broken. And we believe healthcare is a human right here in the state of California, but as well as nationally. That's why you hear us saying Medicare for all as well. This is here to provide universal coverage, meaning we believe that everybody in, nobody out, regardless of your race, your sex, gender, country of origin, disability status, marital status, immigration, income, you should get the care that you need regardless of income. A single public program, this is single payer. It's publicly funded through progressive taxation. What is progressive taxation? That means that Jeff Bezos pays a little bit more than maybe you, because you don't make the same amount of money as Bezos, right? I mean, if you do, congratulations, but I don't. So why, you know, I feel like he should probably pay a little bit higher tax rate than me and not less. Right now, it's kind of backwards. He's paying less, but we'll get in. That's another story, not for healthcare. Anyway, it's progressive taxation. And it's going to cover the necessary care here in California. When we say necessary care, I'm not saying that everyone will be able to go get that elective plastic surgery that they want, but if you have an injury, like right now today, a firework injury, you should be able to go to the ER without having to worry about a copay or some type of deductible. You should be able to go and get taken care of without that. This is going to eliminate billions in bloat and waste, saving people thousands on their healthcare costs. You would think that maybe right now the current healthcare system will lead you to believe that, you know, they're there, the insurance companies, managed care, they're there to control healthcare costs. But what it is that they're paying more money for analytics and analysis than they are for your actual care. They're actually following analytics and the metrics. That's their focus more than providing the care that you need. They're there for the profit, not the patient. And so we want to eliminate that bloat and waste. Why do we need so many analysis, you know, analytics and metrics when patients are still suffering? We still have millions uninsured right here in California, but we have plenty of analytics to tell us that though. So why do we have the analytics but not the insurance coverage? Anyway, fully comprehensive benefits. We're talking medical, dental, vision, hearing, mental health, very important as you see, prescription drugs, long-term care, and more. Most like Medicare, this is Medicare Plus. This is Medicare Platinum level. This is Medicare and more, because Medicare doesn't cover a lot of the vision and dental. It's very limited with long-term care. Actually, Medicare doesn't cover long-term care. It covers skilled nursing, which is separate. And, you know, prescription drugs, there's definitely loopholes in Medicare's prescription drug coverage. While their rates are negotiated at a better rate typically than, you know, other insurances, it still has holes and problems that we need to get rid of because our elderly have fallen into these holes, and that's not good. And your decisions about your care should be between your nurses and doctors and not insurance companies. The insurance company itself is not a provider of care. It is a regulator. It is a clog in the machine. It is not a provider of care. Your insurance company is not the one doing the surgery. It's the surgeon. Your insurance company isn't the one managing your high blood pressure. It is your primary care physician. Your insurance company isn't the one that isn't the nurse that put you on the bedpan. It is the nurse. So once again, your insurance company is not the provider, but they want you to think that because they want you to think that you need them. Anyway, you have a freedom to choose your care provider. Under CalCare, there will be no more in-network, out-of-network. You will have the freedom to choose any doctor or hospital you like. Caveat, as long as they're participating in the program. We can get into that conversation a little bit later, but just like Medicare, and when Medicare became what it was, they had an option to opt out, and just CalCare will give providers that option, but I can guarantee you they won't do that because just like Medicare, CalCare will become the bread and butter. And providers and hospitals alike will not just opt out of this system. So don't worry about, well, I don't know if my provider will jump in or jump out. Likely they're going to jump in because they're not going to want to be excluded from this for 2 years. So then if you don't like your doctor, that means that you will be able to go ahead and you know, choose another doctor. But if you do like your doctor, keep your doctor. Simple as that. No more, well, is this doctor in network? Is this doctor out of network? A better story, I think we talked about this last week too, is that if you go and have a procedure done, you usually find it's in network, the facility's in network, maybe the principal surgeon is in network, but maybe the anesthesiologist that's you know, providing a sedation for you during this procedure is out of network. And guess what? Right now in this current spaghetti bowl of healthcare system, that anesthesiologist bills separately. And if he's out of network, guess who's eating that whole cost? Not the insurance company. And so that is why CalCare eliminates that. They all get paid in the bundle. Anyway, free at the point of service. No more co-pays, premiums, or deductibles. You arrive at your doctor's office, you arrive for that procedure, you have to go to the ER and you show them your CalCare card and they say, okay, fine, you get the care that you need, bing, bang, boom, that's done, it's simple. A just transition. Well, what about the people who work in these industries? I mean, there's thousands of us and who are working in the insurance industry or, you know, providing some type of service on that side. And it is not the employee that needs to suffer due to bad leadership. I say that all the time because I mean it. It rings very true that the little guy should not suffer due to bad leadership, and so many of us do. And so this bill actually has a just transition written right there into it to fund and provide programs to protect and support displaced workers in this industry. And that's something that's very, you know, unique. You don't see a lot of that in bills like this, to protect people, to get them, help them transition. Several of us may need, you know, will probably have a role here right in CalCare itself, because our training does help us, you know, navigate the healthcare system, like case management, what I do. Case management is going to be needed with insurance, without insurance, with CalCare, without CalCare, because still navigating this system can be complex, even with single payer. You will need someone there to help guide and help provide, make sure your medications are there and everything like that. And that's from the heart of, you know, goodness of my heart. I like to make sure you're taken care of. And so with a just transition, people like me and, you know, others will probably be able to just slide right on in. And so lastly, patient care based on patient need. No more financial incentives to provide to avoid providing necessary care. And when that is said, that means, you know, financial incentives, you know, currently the system does have, you know, fraud, waste, and abuse, Stark Law, all these different things right now in play that, you know, to prevent, you know, big pharma from coming and buying your doctor off to just prescribe this medication a lot, or to do a certain procedure, or to use a certain equipment. There are current laws like that, but there's so many ways to get around it. Going back to that bloat and waste, the big spaghetti bowl When you have a lot of added admin and networks, and you got to go through this channel and that channel and this channel and that channel, well, there's a lot of ways that you can kind of sprinkle things in. And so when you're providing, you know, financial incentive no longer may mean, okay, I got paid off by this pharmaceutical company, but it means that, you know what, we negotiated a lower rate with this smaller company or this smaller hospital or this smaller place to do these procedures instead of maybe that higher level of care that the patient may need. So we're going to send you to this lower, maybe lesser qualified place because the rates are cheaper than sending you to this higher qualified place that may get you the care that you need. So that's why it is important to remove that type of financial incentive to be able to negotiate those rates at different places where a cost of something at one hospital is a lot higher than a cost at another hospital, but it's the exact same procedure. Why is that? Why does it matter, you know, what hospital it is and the cost? And so some hospitals can make 10 or 20K higher for the same procedure than a smaller community hospital, thus devoiding that community hospital of additional resources that they could need. So, you know, that's what's going on. And that's what it means to avoid, you know, financial incentives to avoid providing necessary care. It's not as blatant, but just like systemic racism, it never goes away, it just transforms. And that, ladies and gentlemen, is your 7 basic principles of CalCare.
So I'm here, by the way, back. And I, you know, I was thinking, this is Dr. Ron Birnbaum, one of the co-hosts, but this is a team effort. This one of the things that Dr. Bill mentioned, if you missed the intro, he was talking about people. We were talking about people who got like fireworks injuries. So one of the things that can happen from that type of thing, he was talking about how, you know, people might not get care they need because the care isn't free at the point of care. That's something we really insist on from AB 1400 and is one of its main features: care free at the point of care. So you don't make decisions not to get care because you're going to get stuck with a bill. But then there's another thing that can happen too. Like, let's say, you know, your health insurance came from your job, which, by the way, makes no sense. Is one of the things we should be declaring independence of, for like, and so many people need to declare independence from some job, but are tyrannized by some job where they continue. Why? Because that job provides healthcare and they can't go out and start their band, start their business, change jobs to someplace else, go back to school, and even a million things where people get tied to where they are, job locked or life locked. Maybe even in some cases, people will stay in relationships that they need to declare independence of because that relationship is the source of their healthcare. We know that happens, but and all the many reasons to declare independence. But when you get back to what Dr. Bill was talking about, what could happen to somebody who injured themselves, especially in a non-job related injury, like a recreational injury, like fireworks? They then might become disabled, lose their ability to do their job, and then lose their health care and not be able to get the kinds of things they need to get back where they need in their life. So the whole part of our system where there's some idea of some people eligible, some people not eligible, that's part of the tyranny of our current system. So just mention that, but we're always very attuned to answering questions about AB 1400. And so I just wanted to riff a little bit on what Dr. Bill had said, but maybe it's a good time to answer some questions. If anybody here has any. And by the way, Gina, are you able to peek onto, oh, no, I can't hear you. I couldn't hear you there. You might, are you, oh, you're muted.
Sorry,
you're muted.
I'm muted. All right, sorry guys. Yeah, if you are on Facebook, if you're joining us from Facebook land, please feel free to drop your question in the chat. I'm watching it, and so we'll definitely make sure we get your question as well if you're joining us from Facebook. And if you have questions here in the Zoom land, feel free to raise your hand, or there's only a few of us, so feel free to come off mute.
Blurt out.
I've probably asked this before, but can you self-refer to a specialist? I always forget to ask that question. So like if you have a question for, like an internist, and you don't have to go to your GP to get referred, you can just go directly to the specialist, right?
Yes. So the answer to that is yes. So AB 1400 essentially says that any person who's eligible, which is everybody, unless you just maybe if you just were visiting California for a day or something, we still have to sort out your stats, but we'll just say everybody can go to any provider. There's no utilization limits of that kind that say that you need a prior authorization or referral to see any provider. And so that's a straight up answer. But also, many people have something they want to bring to a specialist first, but a lot of people also want to bring their problem to their primary doctor who knows them better, right? So that's a thing too. And how many people in our system don't know their primary care person as well as they might, because our system forced them to switch or shift or change or something like that. So, there's some sub layers to your question, right? Which is how would a system like this change people's relationship to people who do primary care versus specialty? So that's what I wanted to say about it. But anybody, Dr. Bill, you have your hand up there. What do you think?
I love that. That's such a terrific question, Jeanette, because when you look at other systems around the world, like we always bring up Japan, right? Because they have such a high life expectancy. They see their doctors on average 13 times a year compared to our 4 times a year. And that is a great example of what Ron is talking about. If you have that kind of familiarity with your doctor, you're going to know and trust your own doctor, your primary care doctor, your family doctor so much more. You won't feel the need to go to a specialist for everything that you might feel right now in our culture. And that is driving us to kind of a madness of the need, we all feel we need to see specialists all the time. And that's driving up the cost and driving down availability, of some of these specialty care situations. And a lot of specialists will tell you that, that they don't have, that this is out of their area of specialty. So then you'll say, oh, wait, okay, well, I didn't mean to waste your time or my time by coming to see you, so that's another good point as well. Did that happen? So then there's the, if you can kind of parse that down a little bit too and say, okay, so how much of that is a financial decision? Let's say my insurance company telling me, I can't see a specialist. Or is this really a practice, like a medical practice decision-making thing? So is your primary doctor advising you that it's good to see a specialist in this situation? Or is this a group, like a group model, a group practice situation? For example, if you like or you feel comfortable going to a large group, like a teaching facility, like say UCLA or Scripps or someplace with this stellar reputation. Some people like that. They want to go where the research is being done and the science is being done. Oftentimes, the larger the center, the more kind of, you know, hoops and things you have to go through to get to whatever specialist it is. And they might have their own internal processes to get you to that specialist. And that could be a good thing because it really narrows it down. It narrows down the focus to the person who is, you know, yeah, that is precisely the person that you want to see. There's going to be very little waste in that process to end up with that specialist. So that depends on your level of comfort. Some people like the you know, the kind of committed solo practitioner. You know, some people like the big practice. Some people like something in between, like say Kaiser. That depends on your level of comfort. And then you would go with a provider system that you feel comfortable with, you know, where your primary doctor would refer you to a specialist as opposed to you just deciding to go see one on your own.
Right.
Yeah.
Well, I just wanted to add to that, you know, with AB 1400, and I see your hand, Samara. I would definitely get on to you right after this. With AB 1400, providing that access to care is really important. Record, not record, record, not record. It's really important because building that relationship, it builds trust. And especially in communities of color, we do not trust the healthcare system as it is. Being a Black woman, knowing that our mortality rate for moms is so low for the highest, most industrialized country in the world, our mortality rate for Black maternal health is just ridiculously low. And, you know, why is that? I mean, and of course, it's just further leading to the mistrust. We see it with the vaccination rates. And so with AB 1400, being able to provide a consistent connection with your provider that is not strained by regulation and profit. And I know this from firsthand experience that it's not just the fact of the patient not seeing the doctor, it is the fact that the doctor is also constrained with how they can spend that time with you. Sometimes, you know, you might be able to go to a doctor and the doctor, you're just a regular checkup, everything's on time, 15 minutes, bing, bang, boom. You don't need a whole lot of time with your doctor. But there are times, especially as we age and we get, you know, chronic conditions like, heart failure, COPD, we have, you know, high blood pressure issues. You may need that additional time with that doctor to really talk through this medication, to really talk through this condition. And that's where we're going wrong on the provider side, is that we are not spending enough time with the patient to be able to really get them to understand their conditions. And thus they are not trusting, they're not compliant. But it's not just because, well, my doctor's an asshole. No, it's not. It's your doctor's under a tight schedule. He doesn't have breaks in his schedule. And he cannot spend that additional, maybe even 5 to 10 minutes with you because he's already then going to be pushed back behind his whole schedule. But why are they assembly lining this? Oh, well, profit. And so there we go. And now where it's like, if that's not the case, then maybe spending that 5 to 10 minutes extra with that one patient won't make a big deal because that doctor won't have to feel like he's on an assembly line with those patients and his patients on his schedule for the day. So I just want to go back to that really quick because it was really important because I do think this will help us also in the healthcare culture, not feeling so constrained that the doctors have to spend so much time just coding things. I've seen doctors getting written up for not properly coding correctly or not coding in a time frame that the company they work for feels is necessary. So, you know, there's a lot of additional back end stress going on with these providers, nurses too, that is causing, you know, our strain in our healthcare system, and it's all profit driven. And Samara, I saw your hand up, it's down now, but did you still have a question?
Yes, hi.
Welcome, by the way.
Yes, thank you so much. I'm really excited to be here. I'm actually just a student in high school, but I'm really passionate about healthcare and equitable healthcare. So thank you for this. I had 2 questions. So my first one was, does this bill cover people with pre-existing conditions, and does it help people pay for, treatments and drugs they might need, which are very expensive? For example, like I was recently just seeing this thing on the internet about like Zolgensma, I believe. It's a drug for SMA, and it costs around $2 million. And so that's a lot, right? And so I was wondering if this act covers even people who require these really expensive life-saving treatments, or how does that work?
Yeah, thank you so much for that question and welcome. I mean, so young. See, we start inoculating young. I love it. And so thank you. But yes, pre-existing conditions, the only requirement is you be a California resident. That is the pre-existing. You're a California resident. There is no, I mean, even now in the current healthcare system, they are not allowed to discriminate due to a pre-existing condition, they say. There's workarounds to that. I'm not going to reveal all that, but it does. There's workarounds. Now, regarding high cost dollar medications, in AB 1400, it's not written out how they're going to, handle that, but they are going to be able to negotiate drug prices a lot lower than what's going on right now. And so these these big pharma companies have run amok with these medications and drugs and things like that. It's basically a name your price market. But when we become one collective as a state bargaining power, we're then able to go to them and say, you know what, me and my 40-something million people are saying we're not paying this much for this. And I'm like, and there's no reason why we should, because these companies are getting away with basically using federal funds, taxpayer dollars to do all their research to make this medication, and then they slap their own price tag on it and then extort the American people, the Californian people, to pay this extremely high thing. If they have a rare condition or something like that, you should not have to suffer with that. Sure, I mean, it's a new medication. Yeah, it may need to have cost, the overhead covered, but to say a drug needs to be $2,000 a pill when it costs you only 15 cents a pill to make it, that is just completely ridiculous. So the biggest thing is our collective bargaining power to lower those drug costs, so that if we cover that drug 100%, which is highly likely to happen, it's not going to bankrupt CalCare for that one person because it's a high cost drug, because we're going to negotiate those prices down, just like Medicare does, just like Canada does. Now, granted, like I said, once the board is established with CalCare, they're going to really be able to build that out. But for the most part, collective bargaining power is really important with this right now. And then I'll let wait, no, that was Ron that came off mute, sorry. You wanted to add to that?
Yeah. Yeah, well, and so agree completely with what Gina just said, but just because I wasn't, just to make sure I caught it right, was the specific drug that you were asking about, was it Xeljanz, tofacitinib?
No, it's called Zolgensma. It's a drug for SMA. Yeah.
So it's often I know drugs more by their generic name sometimes than their and so would you mind putting it in the chat? But because there's a couple of specific things I want to say about formulary.
It's also called onasemnogene, I believe. Wait, I'll put it in the chat.
Yeah, I was like, sometimes I don't even know who gets paid to come up with these names. They just do.
While you're doing that, this is sometimes discussed by some as a question of like the coverage of what are called like specialty medications. In other words, as some aspects of our biologic understanding of the human body have gotten more precise, then the potential to target them with medications that are useful in a smaller number of people has increased. And that so that has some costs associated with it, as you mentioned. Now, as Gina also mentioned, sometimes those costs may be kind of legitimate, but a lot of them are just extortion. And that problem is the inability of smaller aspects of our healthcare system, as she said, to negotiate prices. So one thing though too is the bill just has a section where it discusses the establishment of a formulary. And nobody thinks it's going to be a very narrow formulary. I think we think that it would be a pretty broad formulary that would give people a lot of latitude and their providers to make these decisions. And then it limits the ability to do kind of like force people to go through prior authorization processes, which often are used to limit access to more expensive medications. And then it also, some of the new kind of more expensive medications are what are called biologic drugs. And it specifically says that on the whole, biologic drugs will be covered. And so, you know, no matter what, you could come up with a price, you know, if something costs $1 trillion, of course, it can't be, you know, like no healthcare system can buy one pill for $1 trillion. Like you can come up with an extreme that's outside of any system's ability. But we think that based on the way the bill is written and its intent and the kinds of things that we've talked about, that the access to that kind of thing is much more likely to be the case. And when you have very, very special cases, see, now you have like this. So this is real, this is something pretty special. That's why we haven't heard about it, or I haven't heard about it. And I'm a dermatologist. That's why my specialty. But you also now have the combined risk pool of the entire state of California to take on the rare, expensive things. See, when you have smaller risk pools, which is what our system is built on, any individual risk bearer within that desperately wants to avoid the $2 million bills, right? Because that's harder for that. So that's part of the idea of single payer healthcare, is to have one insurer takes all the risk, and that's the best risk pool. It can deal with the rarest, biggest expenditures that an individual needs.
Right, and oh, Dr. Bill, go ahead. You want to add to that?
And I would just add that the bill calls for a board that will then, you know, goes over what are acceptable practices, and, you know, determines the standards of care and the level of quality of care. So that sounds like it's huge, like it's somebody playing God or something, but actually it's done all the time now. It's done by both public interest as well as commercial interest. You know, right now it's done, unfortunately, it's done by insurance companies who represent their bottom line, but it's also done by public interest like Medicare, Medicaid, which is Medi-Cal in California, and the VA and Native American Indian Service, Health Service. So they do that all the time. And they're looking at things like the FDA, you know, the CDC, the FDA. We know a lot about that nowadays, having lived through the pandemic, so we can see what drugs are approved or not approved by the FDA. And when it comes to disease control in general, the CDC is involved, or the NIH, the National Institutes of Health. So there are lots of, say, scientific backed criteria for making these decisions. And that's what we want. We want the public to be making the decisions on whether these are legitimate treatments or not. And the expense, as Dr. Ron says, is then distributed across the entire risk pool, all of us. And that's something, you know, I always say it's like building a bridge or a highway. That's something we can all do together that nobody can do by themselves. And that's the experience of every other universal healthcare country in the world. where they can take care of these, you know, fortunately rather rare conditions compared to the entire population that tend to be very expensive. Yeah, I dropped in the chat the provision in the bill in AB 1400 that covers, you know, just a general statement about prescription drugs and biological products being covered. So that sounds to me absolutely it would be covered.
Yep. And then the good thing is too, is that these prices aren't locked in, you know, just like a lot of other countries like Japan. Japan goes through a review every couple years of cost. And they not only compare costs with just what's going on in Japan, they compare it with the rest of the world. How much does the CT cost? Well, I don't think they're looking at America. They know we're extorting cost over here, but they might not look at the United States and ask how much does a CAT scan cost in the United States, because they probably know it's an upcharge. But they look at the rest of the world's markets to see how much is this medication, how much is this procedure costing around the world. And then if it's lower, they may lower the cost, actually lower the cost of it, because it's like, well, you know, why are we paying so much? Or if it's being utilized heavily. So that medication that you were talking about, if it's something that's being prescribed a lot, well, in America, well, we're going to profit off of that. So we're going to up it, you know, we're going to raise that cost like insulin or an EpiPen, you know, instead of lowering the cost because we're using it a lot, then, well, we're going to make some money off of it. We're going to raise the cost. But in other countries like Japan, instead of raising that cost on a high utilizer, they actually lower that cost because it's being high utilized. I'm like, go figure how that works. And so that's another good thing about this, is that it will be continuously reviewed, you know, on a rolling basis for, you know, competitiveness, making sure, I mean, of course, you know, we've got to cover costs and things like that. Everything costs money. But like I said, right now, we're just being absolutely extorted. And it's just wrong. And it's like, it's literally a name your price market. The healthcare system in America is really a name your price market for those who can, those in power. Of course, for the people who are paying, we don't get to name our price. We don't get to say, I want to just only pay $50 for this. We don't get to do that. We're not the ones in power, but the ones who are creating these pricing structures do. And there's more transparency coming on that. Actually, I'm blanking. I'm sorry, guys. It's Sunday. But, you know, the price transparency thing is going into effect, right? Where hospitals have to publish their prices. And there's already some hiccups going on with that. But what I'm expecting people to see, you're not going to be able to find it. It's not going to be like if you go to, you know, bighospital.org, and you're not just going to see that first link. Here's our prices right here. It's probably going to be click on this page, go through this tree. You know, it's not going to be something you'll easily find. Because they weren't necessarily directed to put it in an accessible place. But it's also, you know, if you do find it, I think what we're going to start seeing, what's going to be more public, is you're going to see the disparity in cost. If, you know, literally right here in Los Angeles, a procedure, exact same procedure, let's say you need to have your gallbladder removed and have a cholecystectomy. Well, that cholecystectomy may cost you about, you know, $40,000, $50,000 at a big, you know, tertiary, you know, collegiate system like UCLA, USC, or something like that. But if you go to a smaller hospital that's still capable of doing it, it may, you know, they may not charge as much, not only because they just don't want to charge that much because they're smaller, but sometimes they just can't. Pricing structures can also be based on certain accreditations, certain accolades that you get. Like you might hear, well, we're magnet status. Well, we're top tier this, we're top tier that. And they do have to do things to achieve that, but that also opens the door for them to charge a topper tier as well. And so, you know, once again, why do we have this in our healthcare system? This is not like Yelp for restaurants. This isn't like a Michelin star restaurant where they have Wagyu beef. This is a hospital. And, you know, so we've got hospitals that can charge Wagyu beef prices, but then we have hospitals who are serving underserved communities who can only charge McDonald's prices. And then they can't do the necessarily repairs and necessary upgrades that they need because they're trying to survive off McDonald's prices. But then you've got this hospital over here that's, you know, getting flipping Wagyu beef. So disparities right here in just Los Angeles alone. And yes, exactly. Human rights is a luxury nowadays. Sorry, go ahead, Ron.
Can you hear me okay right now?
It sounds a little distant, but I can hear you.
I mean, one thing I was, can you hear me? Yeah, I think my signal's low. So pick up without me because my signal's low right now. We'll see if I can.
We can actually hear you really good.
Can you hear me? Oh, you hear me? Okay. So what I was gonna say, yeah, it suddenly got better. Some cloud moved or something. So Samara, like, first of all, you asked about it's a rare condition. And that medication, because I was looking, I was like, why don't I know this? And the answer is it's gene therapy for a rare condition. And so first of all, it's a one-time treatment. And you must know about it, but you tell me if I got this wrong, because maybe you know somebody who's dealing with this. You correct me if I got that wrong. And that is, and that makes me think about a couple of things. So one is that people with rare conditions are doubly cursed in a sense by some of the aspects of our healthcare system, because the ability to make decisions based on individual need is very limited actually in our current healthcare system. And that kind of thinking that individuals need, because so often there's somebody managing the bottom line money risk who then sets a set of rules that exclude certain people. And the other thing too is
Ron, yeah, the cloud came back, you froze.
We'll come back to the other thing.
Yeah, we'll come back when the cloud frees up again.
I got
Go ahead,
something
Dr.
to add. Well, so there's a concept called orphan drugs, which are drugs that, that are rarely used. Yeah, they're rarely used and can be extremely expensive because they're rarely used. So drug companies may not, see it profitable for them to produce them, and so that's an issue because the drug companies are for the most part commercial enterprise. So that actually you could use as an argument to develop public pharmaceutical companies, for that matter, which has been brought up by people like Elizabeth Warren, for example. Why don't we have our own public pharmaceutical company? But in the case where things are relatively rare, and they don't have to be extremely rare even. I mean, for example, having a baby with a heart condition, congenital heart problems. That was the case with Jimmy Kimmel's baby, right? So Jimmy Kimmel came on the air and said that he couldn't believe all of the intensive treatment that was required for his baby, for he and his wife's baby, and that he couldn't imagine what it would be like for anyone who didn't have all of the financial resources that they had to deal with the problem, to actually provide for a baby like that. Well, that's not extremely rare. I mean, it's rare, thank goodness, but it's not extremely rare. And I think that that right now, young people, like yourself, who are looking maybe to want to start a family, should be thinking about, okay, what would happen to me or us in our relationship if we had a baby who had a heart condition and would require medical treatment like this. I can tell you in Canada, there's a wonderful film called The Healthcare Movie. And that movie actually juxtaposes Canadian healthcare with American healthcare. And one of the scenarios they have in that movie is exactly that, the Jimmy Kimmel baby. But it's not Jimmy Kimmel in Canada. It's a young couple of, kind of reasonable means. They both, they're working parents kind of thing. And this baby had to have multiple heart surgeries. And they actually had to fly the baby from one province to another. And they put up the parents in a hotel, both parents put them up in a hotel to be able to stay with the baby. They stayed across the street from the hospital in a hotel for 3 months. They didn't lose their home. They didn't lose their jobs. All healthcare was provided, including, you know, payments for their house so that they wouldn't lose their home. Everything was provided publicly by their health plan, meaning the public health plan that they have in Canada provided for all of that. That's not extremely rare, but they could do all of that collectively that nobody except Jimmy Kimmel could do in this country for a baby born with a heart condition. And when it's even more rare, I think what we're talking about here, like say gene therapy and that kind of thing, it's even easier to do that. And it sounds horrible. And you know, people like who resist this idea of us all taking care, you know, it's like Paul Wellstone used to say, you know, everyone does better when everyone does better. You know, so like you know, certain conservatives will reject that idea altogether, that we can't take care of everybody. Like it's a zero-sum equation. If somebody gets taken care of, someone else gets left out for some reason, right? So, you know, that's not the case in every other advanced country in the world that has figured this out and they actually do this.
Exactly. So that's where we go back to, well, why? If you ask yourself why, let's look at the root cause. What is it that separates that America has going on that the rest of the countries are obviously doing something? Because I mean, here in our country, and God bless America on its Independence Day, but here we obviously have to be doing something better. For us, our healthcare system must be superior. And for the rest of the country, the rest of the world to have this universal healthcare thing going on, obviously, you know, and I'm being very sarcastic here, obviously America's figured out something, right? Well, maybe not. We figured out that we can make a lot of money off of sick people. And that's where you see now in this uprising. And well, I just have to give a shout out to our beloved Bernie Sanders, who really put this Medicare for all conversation on the front line. Mittens Bernie, you know, I have to give him a shout out, because without him, and, you know, I've been with Bernie since 2015 and 2 DNCs. Without him, though, this conversation of Medicare for all would not have been there. And then we would not have had, I don't think, that drive to push what we had before, which was SB 562, and then came back only a couple of years later with another bill, AB 1400, here in California, if it weren't for Bernie. So Bernie, if you ever watch this, I just have to make sure that we sprinkle your name somewhere in there. But also going back, is that we figured out how to make money off of sick people, and that is inherently and ethically wrong. And so that is why we are here right now on the 4th of July, having this conversation about this bill, taking time out of our day, and none of us get paid for this. This is strictly volunteer labor of love, to have these discussions, to answer these questions, because even, you know, and to bring attention to this bill, and we're doing this because we want this to get passed. And so we want to make this known between PNHP, Healthcare for All Los Angeles, Progressive Democrats of America, like all of our progressive organizations around California are definitely trying to make more noise about this. We want our legislators to pass it, because we know what happens here in California, the left coast, the progressive coast, even though we've got a big oil fracking problem and a lot of other problems. But, you know, if we can get this done, we'll get it done. Medicare for all, Bernie's dream, will be able to come true if we can do it here in California. But, you know, going back to the bill and the drug costs are a huge portion of why lower income or even moderate income people are struggling to maintain their chronic conditions. We know America has an obesity problem. With that obesity problem comes other health issues like diabetes, high blood pressure, heart failure, chronic obstructive pulmonary disease. That also can be part of our environmental problems. But with that, it's a cost problem too. People, it's expensive to be healthy. If you haven't noticed here in America, to get that organic burger or to get that organic salad, you might usually have to pay $2 or $3, $4, $5 more than it would cost to go get that 99-cent store packet of ramen with 2,000 grams of sodium. And it is not necessarily the fault of that person who cannot afford to go get that organic food to live a healthier lifestyle. So once again, I have to say, and I feel like I'm on a soapbox right now, but I have to say, I see this every day in my work, that it is not the worker, it is not the average citizen's fault necessarily for bad leadership. Yes, we have got to vote better, but at the same time, our leadership has led us down a very dark path that we are having trouble getting out of. So like I said, the distribution and AB 1400 provides equity within healthcare, not equal healthcare. They'll say till the cows come home that right now the healthcare system is equal, meaning you have access to it. If you have the money, if you have the job, you can have access to care. Or if you are low income, you can have access to some type of care. Not necessarily, it is not equitable care. There's a huge medical apartheid problem here, and AB 1400 really helps equal that out, especially for people in rural and low income areas. Why? Because within AB 1400, they are reallocating, not necessarily reallocating. I don't want to make it seem like we're taking resources away from someone to give to another. We're really not. We're just evening that playing field because it is uneven. And so with the rural and lower income, that getting those equitable resources sent to them will help also create a better culture of compliance, a better culture of healthcare trust, and overall a better healthcare America, healthy America and healthy California, and which, going back to GDP, healthy people equal productive people. Productive people equal better GDP. I was like, so I don't know why conservatives aren't rallying behind this, because that concept alone was almost a conservative concept. It's a common sense concept, but that is the reason why we want AB 1400 to provide an equitable system, because we want to be able to provide that care, because those diabetics who have one little foot injury, that foot injury gone untreated means that now you have an amputation and now you may be disabled, because these are our workers, our healthcare, healthcare workers, grocery store workers, restaurant workers, farmers, people out there doing a lot of manual labor. If they have an amputation of their foot, they can't do that manual labor anymore. So now they're living off of Social Security and disability benefits. So we took a productive person and now made them unproductive, and now we're paying them disability. So what sense does that make when all we had to do was provide them the care that they needed at that initial point and got them back on their feet and carried on? And so that is another reason why AB 1400 is imperative. It's almost like we cannot not get this done because, well, it's costing too much for us not to. I don't have any questions on Facebook right now.
Definitely, if there are other. So, Samara, this made me think of a question though that comes up with questions like Samara's. Can you guys hear me okay right now? No? Can you hear me?
Yes, we're hearing you.
So, yeah. So, and sorry about my terrible connection. But one question, Samara, that your really cool and smart question brings up too is like, well, hey, if California was the only place that was covering that medication for that rare problem, does that mean a bunch of people would come from all over the place and try to move to California to get that cared for? And the answer is that is a problem we would like to have, or to put it the way Dr. Bill has recently put it, we would like to be a healthcare sanctuary. And it's not an argument against this bill. It's an argument for it. In other words, right now, we are seeing people leaving California because of the cost of living and all the things they can't that have gotten harder for the first time. We're losing a member of Congress for the first time in the history of the state because of that. But we know that this would be like unleash and like a bunch of great economic things, we think, in California. And how many people would say, I want to come work in a state where my kids are going to get cared for if something like this happens, or I am going to move there because my kid is going to get cared for and I'm going to go there and work. And even if it's like, well, I'm going to go and get the one-time infusion and go away, I still think like that's not how most people think, right? Like that isn't how most people think. That most people would see that there are many, many more examples where people would come because they would see like the sanity and compassion behind a system like this as a sign of a state that's found sanity in the sea of insanity, which is American healthcare right now. So I just wanted to add that one in there.
Yeah, and just
are there
oh, I saw Dr. Bill with his hand up, but I was just going to say that, you know, I mean, there are requirements. You do have to be a California resident. So we don't have to really worry about that tourism, like medical tourism, which is going on right now. People right here in California going to Mexico to get dental work done. What sense does that make? You know, I mean, to my conservative people, like literally people are considering going to Mexico to get their flipping, you know, implants done, not like breast implants. I mean, like dental implants, because it is too expensive here in California or here in America to get it done. So, but we're not going to see that here because you do have to be a California resident to become part of AB 1400 or CalCare. So there won't be any, okay, I'm going to bring my baby over, we're going to get this infusion, we're going to go back home like on a vacation. You literally have to become a resident, which means you do have to work, you have to have a home, which means you have to pay rent. So it's not going to be just really like, you know, easy to just jump over and jump back. So, you know, but then that's a good thing, because then if they come over and they start working, they've established residency, they're contributing to California's already very good GDP. And then they might realize, well, it's quite beautiful here. The ground may shake just a little, but you know, it's quite beautiful. And still, and then you have people who are also going to come who might want to start that business, who can't start the business due to cost of care and all that stuff. So they also will be interested in coming back to California if they left, or coming to California just because, well, I had really good, you know, they really wanted to come out here to begin with. So I do think, like, you know, like they said, it will be a very good actually attraction, more than it would be detracting from our population. Dr. Bill.
Yeah, well, you just hit on that last one. Was what I was going to bring up. I mentioned earlier the movie, the healthcare movie, which contrasts Canadian versus American healthcare, and actually it was produced, directed, created by a couple of very sweet psychologists, family and counselors from Canada, who moved to this country after a whole career in family counseling, and they decided they wanted to make movies. And once they moved here, they had healthcare challenges, and so they said, we're going to make our first movie about healthcare and show Americans how crazy it is what we're putting up with in healthcare in America compared to what they live with in Canada, the reality of Canadian healthcare. So they made these two movies, actually, the healthcare movie, which kind of chronicles the history of how they got Medicare. You know, they call it Medicare in Canada, just like we call it Medicare for seniors. When we got it for seniors in the 1960s, they got it for everyone when we just got it for seniors. So the first movie kind of chronicles how they got it, but they also do these interviews of people on the street, like contrasting people in Canada and people in America. And some of the interviews, I think, because they're psychologists, really get into that psychology that Ron was talking about. That, you know, it's like when you end up here, and Gina too, you know, when you end up in a country or a state that has universal health care, how much more comfortable and secure you feel in your life. I mean, one example, like Gina just mentioned, is starting a business. And I remember they're interviewing someone who just started a photography studio, her own photography studio. That's what she wanted to do in life, was to start up her own photography studio. And they asked her, well, you know, what concerns did you have when you started this business about healthcare? And weren't you concerned that you might not have healthcare, or were you going to have healthcare, you know, in Canada? And she just looked like, well, that wasn't a concern for me at all. Why should I be concerned about having healthcare, you know, as part of starting my new small business? You know, I mean, it's zero concern for somebody in that situation in Canada. And here it would have to be a concern for anybody starting their own business. So especially, like you said before, young people have healthcare needs too, and they're starting their own business at that stage in their life. So yeah, you know, business startups are considered to be an integral part of a thriving economy. And we don't have that in this country because we don't have security in doing that.
Very good points. Very good points. And that's how the American innovation is also stagnated. So we are a very innovatively stagnated country, because I think a lot of it just goes into not just the political interference, but, you know, a lot of it that, you know, people, those ideas never get heard too, because now we're in this kind of corporately monopolized world. But I think that if people didn't have to worry about cost of care, that's a big, heavy burden. That's a heavy burden unions have to carry, negotiating healthcare costs. And I know that right now, one thing about AB1400, a lot of the conversation I'm hearing about people are, well, the unions, you know, are the unions on board? What about my union benefits? What about, you know, what my union has negotiated? But if you had, and I'm just, you know, I'm not saying in either way on that. I'm just really kind of putting the question in people's head, is that if you were under a union and that union, let's say, spent 40% of the time at the negotiating table, maybe it's less, maybe it's more, but maybe they spent that for that particular contract term, that much time at the negotiating table, just talking about healthcare benefits, nothing else, just trying to get the healthcare benefits covered. What else could they have been talking about? You know, like, there's so many other things workers' rights, maybe just to get you an extended break. To me, 30-minute breaks are just a crime against humanity. By the time you get your damn burrito warmed up in the from the microwave, you know, your 30 minutes are half gone. Then you have to scarf your food and return back to work. That's not healthy. And so, you know, I like, that's something that the unions should be working back on, you know. I don't know if we can stop the recording. It keeps, Ron, can we stop the recording? Because it keeps copying on and off. But you know, that's something that with unions, I personally believe, if they didn't have to spend so much time, because you already had access to care, all the care, you know, not just, oh, well, you know, my particular union negotiated the best with Anthem, and so I can go to, you know, I have top tier Anthem benefits. Okay, that's fantastic. But at the same time, if that was never an issue, then that time could be spent negotiating that 1 hour lunch break instead of 30 minutes, huh? Yeah, then you can go actually get some good food. Or that time could be negotiating more uniforms. I mean, sometimes places only get like a uniform allotment, 2 or 3 uniforms a quarter. What, that quarter, like literally 90 something days, I only get 2 or 3 uniforms and I have to work 5 days a week? That doesn't make sense. But anyway, so stuff like that. And like I said, I'm not talking about real union I'm just putting examples out there. I don't want anyone to, you know, say anything about that. That's not what I'm just saying, an example. And so, like I said, when you take that big chunk of healthcare, there's so much more that they can negotiate. There's so much more fire that they'll have for fighting for other workers' rights, safety, for example. Nurse safety has been really a big problem lately. You've seen the videos of nurses getting literally attacked by patients. And, you know, and we're not necessarily trained per se to really fend off those attacks. And then, you know, hospital security may or may not have been even on the floor, you know, when that happened. So those are other things, like I said, unions could have time to negotiate if they're not spending so much time just having to negotiate healthcare. I understand that our union members may really like their healthcare benefits, and I understand that. But if that isn't a problem, if that was never having to be negotiated, what else could it be that you would want that we could have you could have your union reps really go after and have the time to do it, so they're not spending so much time negotiating on the healthcare front. And that's what we're trying to get people to see and understand, that AB 1400 also helps unions fight for things that they may not even be able to get to in the contract negotiations, only because they have to spend so much time just sitting there working out that those healthcare benefits, not just for current employees, but for retirees as well. Those retirees who retired between the gap between before they get covered by Medicare, you know, you might have retired at 45, 50, you worked you worked a long time. And so you still have a gap there, and you still, you know, a lot of people are covered, you know, thanks to their union negotiations, they still get healthcare coverage, and that's fantastic. But if that didn't even have to be there, once again, think about how much money that could be saved and how much power the unions would have again at the negotiating table. Just adding that in there. I don't even know what started that tangent. I'm sorry. Dr. Bill, go ahead.
Well, I want to see that and raise you one. I'm going to kind of pile on what you were talking about before, that big insurance and big pharma are extortion models of business practice, and they're not only pricing their products on what our lives are worth to us rather than what it costs them to provide the service or produce the product and distribute the product. You know, like my thing is always the EpiPen, right? The EpiPen probably cost them about $1 to produce, and they charge people $300 per unit, you know, for something that probably only costs them $1. But insurance is a racket. Insurance is a scam, and insurance has, you know, I mean, if we could, you know, just like we were talking about the need maybe for a public form of pharmaceutical to be produced and distributed, where maybe they could, you know, the public pharmaceutical company could manufacture, produce, and distribute EpiPens. That would be fantastic, in my opinion. Maybe, you know, we're talking about a public insurance, because insurance companies have their fingers, you know, their death grip actually into unions, into public agencies like cities, counties, school districts. They are in there manipulating the people that are supposed to be fighting on behalf of workers, on behalf of citizens, you know, and residents in their towns and schools and children even, and families, because they are telling those union negotiators, the union leadership, what they can or can't ask for. And for example, unions have to hire people to negotiate their union contracts, right, Gina? So you've got union leaders then hiring people to negotiate with health insurance companies. And those people then go back to union leadership and say, well, this is all we can get from insurance companies. And that happens in cities too, and counties, where, you know, their city managers and human resource people will say, well, this is all we can get in terms of a commercial health insurance product from these people. Well, if that's all we can get from them, then that's terrible. It's awful. It's wasteful. It's waste, fraud, and abuse, and it needs to be thrown out. And I'll give you one example of what a scam is. When you ask a Canadian about, you know, well, let me put it this way, not just Canadians, but all around the world. American healthcare has a unique little thing in it that no other country with a universal healthcare has, and that's called workers' comp, workers' compensation. This is such a huge problem for American industry, because every product that you buy, the shirt you're wearing, the coffee you buy at Starbucks, has cost in it that that manufacturer that produced it has charged you as the consumer some money because of workers' compensation. It cost them, they had to pay an insurance company because just in case somebody got sick or injured on the job, for medical liability. If you had universal health care, that cost would disappear. There would no longer be medical liability in the shirt that you're wearing, in the coffee, in that drink that sports bottle that Danette was just drinking out of. That would no longer have any medical liability costs built into it. That's uniquely American. We are putting up with that scam being put on us, placed upon us by insurance companies in America. That would be gone. And so how can we even compete if a certain amount of that medical liability workers' comp is built into, say, I don't know, cars, into cars that we produce in America, into anything that we produce in America, compared to a country where they don't have that cost in the products that they produce. We can't compete globally because of this insurance scam that we put up with in America. This needs to be eliminated like yesterday. And you know, so hopefully, at least, it may not happen in my lifetime because I'm old, but hopefully it's going to happen in your lifetime at least. And you know, we'll do everything we can, or I will at least before I die, to help you guys do that.
And that is why this is a multi-generational, intersectional movement, because we know that our seniors need to be taken care of. Long-term care, we're living longer, not necessarily healthier, but we are living longer. And we need care, you know, and the elderly will need care, and Medicare cuts off, honestly, rather quickly when it comes to the basic senior living care or activities of daily living, caregiving. Medicare is really, really skimp over there on that section. And yet we are seeing these huge gaps that are burdens to families who cannot afford it. Providing a caregiver alone can bankrupt you. And so, and getting a secondary insurance, if you even have a little bit of pension, you know, you're not getting approved for Medi-Cal. And so, you know, it is a huge gap on that side for long-term care. Subsequently, though, you know, keeping the working, you know, age people, and then younger people, children being born, you know, autism, all these different conditions coming up or that are becoming more prevalent, where children are needing a little bit more better, you know, better care and or more specialized care. Not happening. And so parents are struggling trying to find and to, you know, make up for the cost of that care privately. Also mental health care. And that's where I really would like to see AB 1400, even though it's going to cover, but we're going to really need strong mental health care. Which, because our mental health system has been completely devoid of major resources since the Reagan era, which was, I mean, I was barely a toddler. I wasn't even a toddler. I was like very young in the Reagan era. And that happened. And then, you know, we haven't seen that replenishment of mental health resources since then. And so hopefully AB 1400 will help bring that somewhat up to par. I don't think it could bring it all the way up because there's just so much to make up. But I do think we will have to have a heavy focus on on mental health. which is included in AB 1400, which will help create more jobs, by the way, social workers, psychologists, therapists, alternative medicine, holistic care, things like that. AB 1400 can open that door. I mean, so many doors are going to open up with just passing this bill. But one thing I do like to emphasize is that passing this bill does not mean all these doors open simultaneously. This is literally the complex, like Indiana Jones, Raiders of the Lost Ark type level thing. So AB 1400 is maybe one key to this puzzle, and we put that key in, we're going to unlock it, but we have several other keys. It allows the board for AB4 that is described in AB 1400 to be formed. It allows that board to form the committee, like the Citizens Advisory Committee, that will allow them to help build out what is written in AB 1400, get waivers, maybe have to navigate some hiccups that may show up to answer those questions about ERISA that's popped up, the questions about the GAN limit, Prop 98, like all these different things that have come up that we don't quite have answers for yet because we haven't been able to unlock that or put that key in there to see how it's going to play out. We need to pass AB 1400 to answer those questions. But before we implement it, which we want to see, what we're discussing is implementation level, but there's going to be a big step between implementation and passage of the actual bill. And so passage of the bill means that's when the real work starts. Not saying that what we're doing now is not the real work, but for the legislators and things like that, the people who are going to be appointed to the bill or to the board, they will then be able to start building this out. And so that's why we have to pass AB 1400, because we actually have a lot of work to get done before we get to implementation phase. We want to get to implementation phase as fast as possible, but we can only move as fast as the board, once it's established and the committees will be to, will be able to kind of build that out. And so that could take a year. Medicare took a year because they had the president whipping on them to get it done. But then it also could take several years depending on how much, if there's any hiccups, if there's anything we have to overcome, or maybe people might not be as motivated to get this done as we would hope. So there, like I said, but the key here is, moral of the story, we got to pass it first before we can even get there. And then I saw, Samara, you just want to ask your question? I saw you typed it out in the chat. How will you can feel free to come off mute.
Yeah, I had like two questions. One was just that with something like mental health care, which is really subjective in a way, because, as a patient, we might feel like we need therapy, but an assessment might not show that it's like as severe of a need. So how will the system decide after AB 1400 is passed who will get that care and who won't? And my other question was that if people are allowed to visit any healthcare provider, which I must say is a great effort, because people who do have the resources tend to get better care because they're able to go to more reputed or even clinics and hospitals with better resources. But I was wondering, how will these hospitals and clinics, which are well resourced, have a lot of research and treatments, be not overcrowded, and small clinics and hospitals not be left empty?
Yeah, that's actually a really good question. Some of which, like I said, definitively, I can't quote from the bill because it has to be written out still, but it is in there. So for example, mental health, like you said, very subjective. You cannot tell me what I'm feeling, and that's, it goes back, that was something we see a lot with pain. Pain can be objective. Because you can see that, okay, well, someone who's in pain, their heart rates increase, their blood pressures increase, but sometimes not really. Some people who are dealing with chronic pain might not show some of those. But at the same time, you do have to listen to the patient. And so with mental health, it's even more so listening to that patient. Right now, our healthcare system is so broken that if you went to the ER and said, you know what, I'm having a mental health crisis, I've been really sad, you can't deal right now. You're just not able to function. We're seeing that so much right now, especially with young people, teenagers, we're seeing that really, really heavy. And there's, what they're going to ask you, do you feel like you're going to kill yourself? Do you feel like you're going to kill others? No? Okay, well, go home and follow up with the mental health provider. And that mental health provider, when you're having a crisis like that, guess what? The last thing you're doing is calling the 800 number for member services on the back of your insurance card. And so that's where I said we're a failure. So going to your question about like how to determine who would get services and who wouldn't, well, with AB 1400, you should not have to utilize just the ER. So with AB 1400, with CalCare, you should sit there and be able to just look up, psychiatrist or MFT or therapist in your zip code, call them and say, can I come in? Do you have an appointment time, that I would like to be seen? And then with CalCare, if they're a CalCare provider, that's that. You go to your appointment and you see them. Now, because with mental health, that's not that should not limit you from being seen. Now, what type of treatments? Yes, I'm sure there's going to be still criteria. Do you need antidepressants? Do you not need antidepressants? Do you just need to be on a therapy plan? Do you need to talk to a therapist once a week, twice a week, whatever? But you should be able to get that mental health care you need. And under CalCare, now that it's covered, that's a big portion of the issue is that cost, especially with psychiatrists and therapists, because they have to pay their bills too. And so a lot of it is, them making sure that if, they have either high private rates or you have to find if your insurance covers that. And that's the reason why we see such a failure in the mental health system is because when you're going through a mental health crisis, and if you don't have someone there doing it for you, which, oh, by the way, we can't because of the certain privacy laws. Like if you said, Gina, as you're my case manager, schedule my appointment to see my therapist or psychiatrist, guess what? I can't. All I could say is call this number, but I can't help, and that's what's so sad. The caveat to that, what we've gotten to do is that I'll do it with you on three-way. So that's how we really have gotten around that loophole. But it's really sad, right? Currently, right now, if you're having a mental health crisis, I can't just send you to a psychiatrist. I literally have to say, well, call this person. But then if that person doesn't have the time or anything, it's just, but now under AB 1400, you have your CalCare card, you find a therapist and that's close to you that you like, or someone referred you to, and then you call them, hey, I have CalCare, and I would like to see you. Do you have availability? Yeah, I have availability tomorrow at 5. Okay, great. And you're done. See that therapist at 5. And then your second question about how are we going to stop this shift in resources? Everyone's going to want to go to the big name hospitals, right? Like if you're going to have access to care, you're going to want to go to Cedars-Sinai, right? Because that's a pretty hospital in Beverly Hills. I want to go to Cedars. Not really, but anyway. Well, first, have you tried getting to Cedars in the afternoon? Like if you live in South LA, getting to Cedars ain't happening. Just putting that out there. So, but there is MLK Hospital, which is there in South LA and Compton, which under AB 1400, granted, I keep saying I'm going to be appointed to the board because they're going to have to do a health risk analysis and find out where they need these resources, which is actually written in the bill to kind of put those resources into rural healthcare, into low income neighborhoods. So MLK Hospital may get more resources in the initial than UCLA, because UCLA may not need it right now. UCLA is doing well, Cedars is doing well, but maybe MLK needs it. Maybe, Huntington Park Hospital needs it because they're small community hospitals that should be serving their small community. The patient should not have to go and drive, up the 110 to the 105, blah, 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 to get to Cedars to get the care that they need unless it's a specialty care. And so with AB 1400, resources are actually going to be better distributed, not taken away. UCLA, Cedars, the big hospitals will still do what they do. Shine on, homies. But, but the resources will be spread a little bit more even. So Huntington Park Hospital, Community Hospital of Los Angeles, the recently closed Olympia may not have had to close if AB 1400 was there. Actually, Olympia got bought out by UCLA, go figure. That's another problem. Hospital monopolization is going on too. Like the big guys are chomping up the little guys. And then it's not even going to be a full-fledged hospital. That's the problem. You just took a hospital out of play during a pandemic and you're not even going to keep it a hospital. Don't get me started on that. Never mind. But yeah, so you'll see a distribution there that should be better. Dr. Bill, you want to add to that?
I would kind of summarize something that I think you're saying, Gina, for Samara, and that is that right now you have commercial entities allocating those resources, okay, and that depends on what their bottom line is. That depends on, you know, what they consider to be within their business model, their operating business model. Whereas with CalCare and the AB 1400, it's the public deciding these things. It's us, it's we the people deciding and allocating those resources. So like you said, if there are not enough appointments available with mental health providers in general, right now, people end up in the ER. I know, I have a whole career of that. I've seen people in the ER. In one of the best designed, you know, care model group of practices. I worked for Kaiser for over 30 years, and they were not giving enough appointments in mental health, and people were ending up in the emergency room with mental health issues that would have been taken care of if they had more appointments in mental health, outpatient appointments, in my opinion. So that was because of the business side of Kaiser saying that they didn't have enough, you know, they didn't have the resources to hire more mental health workers so that they could have more appointments available. That's a terrible business decision that impacted the providers inside Kaiser. And like you said, it ended up being much more expensive to take care of people once their mental health condition got so out of control that they ended up in the emergency room. So I think that's what we're talking about here is public decision making, where you have, you know, boards of people like we're talking about. CalCare AB 1400 establishes a board that oversees this, and the board then will see, okay, like Gina says, you know, a place like Cedars-Sinai or UCLA has enough resources where MOK may not, and we need to get more resources into MOK or, you know, LA County USC or other places that needs more resources. So that's why, you know, again, another reason why we need to get these the middleman out of the decision-making process, and, you know, make it us who are making the decisions, not these commercial interest intermediaries. And you know, it couldn't be more apparent. I would just give you one kind of final example. You know, I think mental health is a really good example, but an even more immediate one is COVID, is the pandemic. And that's why this country failed so miserably to protect the most vulnerable people in the pandemic, was we didn't have a real public health system where the public was making the decisions, not just on vaccines, that's actually the part we succeeded somewhat at, but at testing, early testing, contact tracing, and then taking care of all of those medical conditions that put people at risk. We failed at all of that because there was no public input into the decision-making there. And that's what we're looking for with a single payer system, whether it's for California or nationwide.
Absolutely. Yeah, I mean, you know, like I said, it's just getting our biggest barrier right now is getting our elected officials on board. You know, we have some pretty strong people in the assembly who were the co-authors of this, and the author, shout out to Ash Kalra, Miguel Santiago, Cindy Comlager, who's now in the Senate, Alex Lee, a whole slew of others that I am forgetting. But, you know, I just want to give a shout out to them because they are championing this in our assembly right now, where the bill will be coming back in January. But in the meantime, we're trying to make as much noise about it as possible, getting the public up and aware of what's going on. And then also making sure that, you know, the other assembly people are on board, or we're having conversations with them, you know, because this bill is very important. And Unfortunately, what I'm finding is that not everybody has quite read it, and that's fine. You know, that's why people like us are here. But, you know, we are definitely wanting to get this passed and get it moving. So we're definitely trying to bring awareness to our elected officials. And then side note, I think, Ron, you're not at Dodger, you're at the Galaxy Stadium, the bank. Oh yeah. Oh, Dignity Sports Park.
Yeah.
There we go.
Yeah. Can I say something? I'm at this tennis stadium that's part of which is quieter than the main stadium. The game hasn't started, but it's a little quiet place. So I'm not finding it. But you know what? Just quick thing, which is, it would make no sense for a hospital system to have to sponsor sports teams, because it just wouldn't make sense under this other system. In other words, like, there's money going to that too, by the way, right? Like, which doesn't make sense. So anyhow, yes, that's where I am, at Dignity Health Sports Park.
Well, there's that too. You have enough, when you have so much money, you get to sponsor. You get to have your own sports like park, and that's crazy. I don't see anybody else have any questions. I don't see any questions on Facebook. I know the sun is starting to set and people are starting to get in their fireworks mode. If you're watching from California, please don't burn the state down. You know we have a drought, and please don't blow off your fingers. Don't burn yourself. Like we just talked about this in the beginning, it's expensive to go to the ER. But, you know, I just, you know, definitely hope that everyone's out there enjoying their 4th of July safely. I'm going to get on my COVID high horse for a minute. Delta is real. I'm not talking about the darn airline. They're real too, but Delta COVID, the variant, is real, and it is highly transmissible. And, you know, if you are unvaccinated, then you must be out there wearing a mask, because there is just no way that you will not get sick at this point. If you don't, like, the numbers are showing it. Unvaccinated people are, and especially young unvaccinated people, talking to you millennials, talking to my own people here, you know, being young is not saying that you are immune. So I just wanted to be on my little COVID high horse right now. I know everyone's out celebrating. I see it. Great. It's glad to see people. It's good to be social again. We're social creatures, but just do it in a safe way. And then don't blow off your fingers. Don't get burned. Don't kiss people that you don't know, as I always say. Dr. Bill, do you want to add something? And then, oh, Danette, I saw you came off mute too.
Oh yeah, I just wanted to say I'm doing safe things tonight. I got a new stroller for my cat, so I'm taking them for a walk.
Ooh.
Yes, I am a crazy cat lady, I admit it.
I have thought about it. We both have the same black cat. I'm thinking about getting the stroller and going for the walk.
I'll tell you how it goes.
Let me know how it goes. Dr. Bill?
Well, I don't know if you're wrapping up, kind of sounds like it, but I was going to add to Ron's comment about the scam that is promotions, commercial promotion of health entities, and a lot of people bring up pharma, of course, but you know, since prescription drugs are covered under AB 1400, as we said, what is it, Section 2, Title 23, Chapter 4, Benefits, C4 section, all prescription drugs will be covered under AB 1400 CalCare. How many, you know, drugs will still be promoted? How much of your cable news that you watch, you know, how much of your MSNBC and CNN advertising is going to be packed with all of those crazy drug commercials that say, ask your doctor, and then list 100 possible side effects that you could get. You know, how glad will we all be when those disappear, because drugs are covered by CalCare, and they're no longer going to have you ask your doctor about those drugs. So
I see 90% of the commercials I see are freaking pharmaceutical commercials. It used to be beer, and what was the other thing? Beer and something else, but now it's all pharmaceutical commercials.
Yeah, cars and
beer.
Pharmaceuticals, unhealthy food. Look at Pizza Hut. Here's this super ooey cheesy pizza, and I'm not going to talk because I had pizza last night, but still. And then I see Ron, you're eating pizza too.
Ron's just chowing down over there.
I got called out.
Well, the pizza thing, I wasn't even thinking about pizza. Just the first thing that came to my mind because you see so many commercials, pharmaceuticals and food, and like we're just being brainwashed. But you know, you're right. It is very driven to that consumerism there, and it for the wrong things. Like, why is it that we have so many pharmaceutical commercials? Because when you travel to other countries and you turn on the TV, you don't quite see that those heavy advertisement for pharma. And it's like, why is that? I mean, is it because America's that far ahead of the game that sarcasm? That we're advertising our pharmaceuticals like this? It's kind of like, well, why is it that we have to advertise so much pharma?
Yeah, it's go ahead, Ron.
No, although actually, I'll tell you, I don't think it'll disappear in California from AB 1400, and that's because I think one of the reasons that that drugs are advertised to consumers to try to get them to ask their doctor is because it's their doctor making the decision and them not maybe not getting stuck with the bill. So I don't, in the spirit of like full disclosure, I don't know that California under AB 1400, in other words, I think it's a product of big pharma money being out there, and that I think it wouldn't disappear. Just want to say that. So, and I know it's, and also partly because, sometimes I think we're at risk of saying like AB 1400, it'll mow your lawn. It will, it will walk your cat. It will, and we know that our healthcare system is more merely than just the insurance part of our healthcare system. We know there are problems like that, the individual racism of people who are racist won't go away the day that the system is paid differently. Although I think it will go a long way to repair some inequities that I heard people talking about while I was getting my food. And so, so that also when we do say things that we think it's going to be, because there are a whole lot of things it will fix, right? It will really fix a whole bunch of things. So we're not just saying it'll fix everything, just a whole bunch of things. Sorry, Dr. Bill, I know you had your hand up.
Well, what you haven't said yet is, and you could very well be right, because, they might, what is that, like direct to consumer advertising might still be high on their list as a priority in their whatever kind of warped business model that pharma has adopted. But once we can negotiate down prices, they will no longer have that discretionary budget for that business, at that part of their business model, where more of their budget is in actually developing the product and distributing the product. And that's what I think they're paying for in universal healthcare countries. They're paying a more streamlined price based on the cost of production and distribution. Here, we're being hoodwinked into requesting things that we really don't need of our doctors. First of all, because we don't get to see our doctors very much, and therefore we don't know what to ask or not ask of our doctors. And then secondly, because they can flood our brains with this crap on TV, and then we really end up confused about these things. So advertising is just this, it's just a field that's rife with corruption. And once we deflate the whole situation by negotiating down drug prices, then I think you see most, if not all, of that problem disappears.
Fair enough. It will solve that problem then. It will walk your cat too.
I may use that as a conversation point, I'm just saying. But it may keep you healthy enough to continue walking your cat. That's the thing. So it's a key. Like I said, it is a key to help unlock a lot of doors that we can just continue to build off of if they would just pass it. Just pass it. I'm kind of to that point. I'm just like, just pass it. Just do it. Just help us here. Just do it.
Just do it.
Just do it. You really don't. There's not a lot of risk right now for a person in an assembly to do this. They may think that there is. Maybe they're getting some donor money or something like that they might think will be decreased if they pass this, but not really. Because like I said, we're the passage phase to implementation phase. There's a lot of work that has to be done in the middle. And if this is not able to be done, if there's something that really is preventing this, then at least we know. Right now, we can kind of hypothesize, we can pontificate, we can say there's research, but we haven't been able to build yet. And so with passing this, it allows us to start building, exploring, pursuing, getting waivers, doing all of that. But until we pass it, we really, it's really going to be hard to start putting that full steam ahead and to do this. And so it's really not a lot of risk, because even if we can't, we're not going to see California's budget go belly up because we implemented something that was, very expensive the following day it was passed. That's not going to happen. It's not going to happen, period. And because before we implement that, we have to prove that it's sustainable. We have to prove that we have the revenue, the income to do it. So a lot has to be proven. And that's why I say the implementation phase, there's a lot of work to be done after the passage. There's, and how fast that happens. Well, that's the will of our politicians. Of course, the activists like ourselves, we will keep the heat. But, at the end of the day, it comes straight to political will. It's not about it can't happen. We know it can. The rest of the world proved it. It's about, do you have the political will to put up the fight to make it happen?
Definitely true. And in that sense, there were some people who were like, we had a small group today. Who knows how many people were out there on Facebook Live? But one of the reasons why I was like, what, we have a streak, but also just like, are we doing this on 4th of July? Absolutely. And there's really a kind of, there's such a strong parallel at some level to the holiday. And it speaks in part to some of the things I think Gina just said. So one is, you've operated under a system that over time never made much sense. And then over time has just really, really obnoxiously become clearly not made sense at all. And you've had to say, we have to break the bonds that cannot connect us to this old past system. Like we've got to change it. And at the same time, we also know that it's not as much as we think it would lead us to a better place, that it will set off a whole new work of implementation that Gina was just alluding to, and that the trigger doesn't really get pulled with just passage of the bill, but that also it becomes the political work of the system to deliver on the promises, and that work won't go away. We know that, right? In the same way that the promise that the American Revolution would sort of fulfill the fact that all men are created equal, already leaving out women, already leaving out a whole lot of people under that rubric. We know that this holiday both reminds us, I think, of the need to make a clean break with some big aspects of the past in healthcare, and we also know it won't be the end of we know it won't be the end of the work. it will clear a playing field in a way that getting rid of what's tyrannized our system. So much will become more clear. And then, yeah, you still have to make tough decisions and so, we're close to our time. Are there any outstanding questions out there for any?
Nothing in Facebook land. I know, like I said, everyone out there getting ready for fireworks. No lost fingers, no burns.
Should we maybe just declare a 5-minute holiday then?
Yes, let's declare our independence from the medical industrial complex, for-profit healthcare, and give everyone five minutes back.
All right, then let's leave it there. We'll see you next week.
Hey guys.
Bye everyone. Take care.
Happy
Happy 4th of July, everyone.
Thanks for joining us, Samara.
Thanks for being
Hi,
our
Samara.
champions.
I'm
We
going to be
appreciate
here
it.
next week. Thank you guys. I really
Great.
learned a lot.
Thank you. Bye.
Wonderful.
Love having
Thank
you.
Samara.
Thank you.
Great to have you here.